Good morning. I am feeling sufficiently humbled to be on a platform with the likes of Pat and Brian and Lee to come still. I'm going to come at this from a slightly different angle. I've been very, very lucky to be working with the Eaglet Eye in my hospital clinic for the last 6 weeks or so in the UK. And for anyone who knows the UK system, the 6 weeks is not a long time, so a lot of this work is still in progress. But this is a real-life patients that I'm seeing in practice with a relatively challenging time schedule, and just a few of the uses that I'm starting to see with the Eaglet Eye in practice. A couple of disclosures: that I don't have any financial interest in this product, and I am a paid consultant to Bausch & Lomb Scleral Lens division. So the challenges from specialty lens fitting, as I see it, are that our parameters are, up until this point, being relatively unknown. Until measuring the sclera has been a case of using an eye impression, for example, to get these parameters. But now we're starting to see methods that we can get these parameters more easily, for sure. And what we're looking at, as we've already seen, is toricity, irregularity, and other features on the sclera that we don't know so much about previously. And also the properties of the conjunctiva is a challenge. We don't know how squashy it is. We don't know where it's more squashy than others. And this has an impact when we're using specialty lenses that, by and large, are resting on the conjunctival and scleral surface. So these are a couple of case studies that I put together on patients who are particularly interesting that I've scanned with the ESP in practice. This is a 22-year-old young man with Down syndrome who had presented to a specialty clinic with a history of reduced vision over the last 3 years and an increase in refractive cylinders of around about 3 diopters. Mum had noticed that he was walking into things, he wasn't spotting things so early, and he was complaining that his vision wasn't as easy as it had been. He's never been able to tolerate spectacles, and especially now with the increases in cylinders, he certainly couldn't. Clinical examination was by the consultant diagnosed early keratoconus. Measuring with Kay's pictures, he was significantly worse in the right than the left, and he was eccentric viewing with the right eye to achieve the image. So, discussion with the patient. Scleral lenses, for those of you who've worked with children or adults with Down syndrome, scleral lenses and keratoconus, scleral lenses are a really good option for them because they're inherent eye squeezers, so it's quite difficult to get contact lenses into patients with Down syndrome. They're really, 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 really squeeze tight, but at least with a scleral and a good diameter of scleral, you can actually get them under the upper lid and into the eye, and with outstanding results in a lot of cases. So for ease of application, scleral lenses really appeared to be the only option for this patient. And also they don't decenter during wear. We have eye rubbing issues and obviously a tolerance issue, amongst other things. So I popped some scleral lenses into this chap, and both 20mm and 18mm diameter lenses gave me significant, unacceptable blanching in the horizontal meridian on the patient. But there was a significant improvement to his visual acuity straight away with his right eye that he was eccentric viewing with. He was able to look straight ahead, and he achieved an acuity very similar to the left eye and very slightly better. So there was an immediate improvement and immediate reaction from him that this was going to be a way forward. He's a very difficult chap to image, and actually this shows the quality of what we can achieve with the eye surface profiler. I was able to image him fairly easily with a little bit of bribery in the form of chocolate, I'm afraid to say, but he loves chocolate. And actually, this is the image that I managed to get from him. Now, what we can see here is an elevation towards the nasal side on the sclera, and this is matched up almost identically with where I was seeing the compression on the lens itself, the area of blanching on the lens itself. You can see from the measurements along the top scale there that this is in around about the 6.5mm, 6.5 to 7mm zone, with the height of the peak of the elevation on the nasal side. So just on where those scleral lenses are starting to come to land down. Now, unfortunately, he's not, as I said, the most easy chap to image. This is not the same eye. This is the other eye. But you can see a similar area of blanching being caused by a scleral lens on the nasal side due to this area of elevation. This is the lens that we eventually made for him that he's now wearing very happily. And this is the right eye. And you can see that the blanching really is very acceptable, and it doesn't look clinically of any concern there. He's very, very happy and has achieved really good visual acuity. So, in fact, the lens itself was not made as a result of the ESP in this particular case. But what we're seeing is potentially there is a way forward for these challenging cases to be taken on using data that we can all access without perhaps a level of expertise in dealing with these particular cases. Case study 2, this is a 32-year-old male wearing a piggyback system with advanced keratoconus. He's a serving police officer working long shifts and really struggling with his current lenses. This is his topography, measured with the Eaglet Eye. And again, with a similar level of ptericity in the peripheral sclera with this patient. Again, these are his best corrected acuities with his piggyback system in place. 16.5mm scleral lens gave an immediate improvement in vision. We pretty much 6/6 with both eyes. However, we got this asymmetric toric fitting pattern, and you can see why looking at the Eaglet Eye. So we don't need to put the lens in at this stage to see that we're going to get that fitting pattern. And it was unacceptable. It's causing limbal congestion with the lens on eye. We turn it round, we can look and see how much elevation we've got at that, in that scleral zone, in the scleral zone height there. And if you look on the scale on the right-hand side, you'll see that it sort of equates to in the region of 150 microns of elevation. Interestingly, with this patient and the previous patient, the elevation was approximately the same. And both of the lenses that I've showed, the previous lens that I've shown and the lens I'm just about to show you now, the amount of ptericity on the lens is actually a millimetre of difference. So what we're starting to see is there may well be a correlation between the height differential that we see on the eye surface profiler to the amount of ptericity we need to work on lenses. And that's useful information as a practitioner, but it's also useful information as a manufacturer point of view. So the lens with the toric periphery on the right and with the standard periphery on the left. And he's now successfully wearing the lenses. This is his other eye, and the interesting the reason I've put this one up here is that we still see this asymmetry and we still see this irregularity on the sclera, but you can also see that on this eye, the ptericity is actually much further out. We're into the 8.5mm zone, which is actually just beyond the borders of the 16mm scleral lens. So actually we didn't need to do a toric periphery on this eye because I could see straight away from the ESP that we're not going to encroach on that with a 16mm lens. And a third case study, who was a 24-year-old male with bilateral keratoconus. He's a builder working on a building site, lots of debris behind lenses, can't wear his corneals, and doesn't wear his spectacles, so is coping unaided at the moment with reasonably poor acuity in the right and manageable acuity in the left. Fitted a scleral lens happily to his right eye, which he's delighted with, but struggling with a pinguecular feature on the left eye with the scleral lens. I don't know if you saw my talk the other day, it's the same slides. So this is the game of spot the pinguecular. You can just about see it under this nasal edge of the standard scleral lens just here. But when you take the scleral lens out with the standard periphery, it's very obvious where the pinguecular was compressed under the periphery. If I'd have done an ESP first, which I didn't, I did it after, but if I'd had the ESP first, I would have clearly seen where the elevation was. And the issue with this particular patient is that I've made standard pinguecular notching lenses previously, and this is a standard pinguecular notch you can see on this nasal side. But the difference in this particular case is the actual location of it, and you can see that the pinguecular itself is very, very close to the limbal area. Getting the scleral lens to seal with a notch that would require to go in so far towards the limbus is a real challenge to get that lens to seal and unlikely to succeed. So actually what we're working for on this particular patient is a microvolt in the periphery of the lens to help with the pinguecular situation. This is a work as yet unfinished, but hopefully a good case study to print when it's done. And the other thing I'd like to just bring in is something Pat brought up before as well. I've been lucky enough to be trialling the Rose K2 soft lens in practice recently as well. And I can certainly see an application in the, for the ESP in this this area. The challenges of fitting soft lenses for keratoconus are that we all think that soft lenses fitting is routine, but it's not. It's really difficult. There's a very different mindset that you need with these lenses. And actually, the starting point can be a real challenge to get that right lens. You have to go through numerous trial lenses in order to get that correct fitting. And what we need really is a system of predictability so that it minimizes chair time, and minimizes the discomfort of the patient. Because if you put steep lenses in, the soft lenses for keratoconus, they really hurt. They're not comfortable lenses to wear. And it does demotivate the patient. We don't know what the settling effect is going to be. It's unpredictable. And we also don't know what the peripheral fit of the lens is likely to be like. So I think the ESP really gives us this ability to help with this. What I've come up with so far from the work that I've done on 17 patients in practice is looking at the use of the best sphere function on the ESP, as opposed to using mean or sim-Ks to predict the initial lens. And I'm finding fairly consistently that fitting, using the best sphere function on the ESP is that I'm fitting 1.2 millimeters flatter than that, and I seems to be fairly close to my final lens in most cases. So it's still got further to go in this, but I think it's certainly a very, very useful area for this machine to fit these challenging corneas with these new technology and soft lenses that is available. And this hopefully is something that this would avoid, which is a soft lens that was fitted too tight. Clearly not a happy patient. So hopefully we can avoid that with some use of this technology. So from what the future holds for the ESP, in my opinion, it's facilitating a better level of clinical skills for people who are already dealing with these sorts of cases, and helping us to help the patients even more than we do at the moment. It enhances our clinical skill, and it makes it accessible, I think, for people who perhaps are not as confident in these areas as some of us, to make modifications to lenses. From a costing point of view, I think from a patient point of view, it certainly has cost-saving benefits to the practitioner. You've got chair time to consider, you've got lens replacement to consider, and from a manufacturing point of view, we are certainly not, hopefully not going to see so many lens returns and things that do cost everybody time and effort, and I think the ESP has a great role to play in that in the future. Thank you.